Hi there everyone, this is Neil, writer, also known as the Wax Whisperer. Thank you for tuning into my latest video. It's a very interesting and complex case. This lady attended a couple of weeks ago with a fully impacted left ear canal. She's been symptomatic for quite a while, but for one reason or another, the patient's never really got around to having her ears cleaned out, and obviously with lockdown, she wasn't able to visit during that time period. Now, the client, unbeknown to her, possibly has one or two conditions. She either has a canal cholesteatoma, which is very rare, or more likely she has a condition called benign osteitis. So some of you may already know and heard of a cholesteatoma. Cholesteatoma is a collection of dead keratin that generally collects in the attic region, so the top part of the eardrum. When the eardrum becomes retracted, there's a pocket at the top of the eardrum, and as dead skin sheds, typically it migrates out of the ear. But if you've got a retraction pocket, this dead skin can collect at the roof in the attic of the eardrum. It can then get infected and it can cause serious problems. You may have seen some of my other videos of patients who previously had a cholesteatoma and how enlarged the ear canal became near the eardrum in the attic region. With a canal cholesteatoma, it does obviously warrant urgent treatment, but it is very rare. Cholesteatoma, as I said, normally occurs in the eardrum region in the attic, but very occasionally it can also occur in the ear canal. So you'll see that a bit later on as I remove this outer layer of wax. So it's either a canal cholesteatoma, or, as I said before, it's more likely benign osteitis. So benign osteitis is when the floor of the ear canal becomes exposed and infected, and debris can collect in that widening, that crater that's created. So just to explain what benign osteitis is in a bit more detail, so the tympanic plate bone, which makes up the floor of the bony part of the ear canal, can sometimes have a poor blood supply, and as such it undergoes a process called avascular necrosis. So because that bone is not receiving the adequate blood supply, the bone becomes dead, it dies, and it then just falls out in pieces, and therefore creating a widening, an expansion of the base of the floor of the ear canal. And you'll see that in a moment. So once I remove this wax, it'll become more evident. That dead bone, it typically dies over months, years, so it's not a quick process. Where that bone has become exposed, it can heal itself. You can have kind of obviously the skin regrowing over that crater, but it does leave it open and subject to debris and dead keratin collecting inside there. And if someone has benign osteitis, it does require regular cleaning. And sometimes it can get infected, you can get a bit of discharge, a bit of otorrhea in that area, and therefore the patient will also need to use antibiotic ear drops. So as you saw, I was using the Zollner suction probe. It was very sticky, this wax. When I say sticky, it's more like butter, very soft and gooey as well. So I put some olive oil drops in right at the beginning, went back in with the standard Zollner suction probe, but then I decided to revert to a Jobson horn. Because the wax is quite lateral near the entrance, we're able to use an ear hook or a Jobson horn even if the ear canal is fully occluding, because we can make a bit of contact with the canal wall. The outer third of the canal wall is made up of cartilage, and it's got a thick layer of skin around 1 millimeter in thickness, but the inner 2/3 of the ear canal, you have a very thin lining of skin that coats the bone. That lining of skin is almost 1/10 of a millimeter, so 0.1 millimeters, and therefore it just makes that part of the ear canal very uncomfortable and sensitive if you do make contact with it. And you can see now, so this is this dead keratin, this widening, this crater at the floor, the base of the ear canal and the bony portion. It's a shame that I didn't record live audio, because you would be able to hear when I make contact with that dead keratin just how hard it was. It kind of emitted a ping noise when I made contact with it. But we will come back to that a bit later. So the main mission at the moment is to remove this occlusion, this wax. And you can see it's got the consistency of butter. It's really dense and thick and sticky. It's the worst type of wax. I don't really enjoy removing this type of wax because it's quite a tedious process, but I can't complain. I treat what I get, and actually it does test you, so for that reason alone I don't mind them, but it's one of those ones that I think, oh no, I'm prepared for it being quite a long procedure. So just a slight gap there at the top, and we're just at the juncture of the cartilage bony part, so I've just managed to get a Jobson horn in there, just in that gap, and bring some wax forwards and release it and extract it from the ear canal. I'm now going more in the centre. So when you've got soft wax like this, like butter, we're able to use the Jobson horn and go directly into the middle of the wax. If the wax is firmer, however, you wouldn't be able to do that because you'll just be pushing that further in and against the eardrum. So I just loosened and dissected some of that wax in the middle part of the plug, put some drops in, and I'm now just going back in with the Zollner suction probe to see if I can vacuum a bit more. And again, you can see that crater, that dead keratin, just in view there, kind of the bottom right of screen. You can see it's very light in colour, so that's dead keratin in that when it's that shade. And you can actually see that widening as well. You can just see where I am now, that's the original part of the ear canal wall, and you can see as you go down it rears off to the right, so that's that widening. So all I'm trying to do here is just trying to loosen this wax off the canal wall. It's very hard to use different instruments. A bit later on I managed to, you can just see, I'll just go back to that, you can see that I was just wiggling the Zollner suction probe, and that's because it got blocked, so I just wiggled it whilst it was in the ear to try and unblock it, and it did. You can imagine if you've got a container full of butter or margarine, and you can just use a spoon and scoop that out, and you're not worried if you make contact with the base of the container. But imagine that base of the container being a very sensitive part of your ear, and also your eardrum. You can't just go right to the bottom of the container and scoop it and scrape it, because if it was your ear, because it would be very uncomfortable, be causing bleeding, bruising, possibly perforating the eardrum. So here we kind of have to rely more on suction, which is not ideal, as I said, because of the consistency of the wax. I think in total I used drops, both sodium bicarbonate and olive oil drops, I think 3 or 4 times during the entire procedure, just softening layer by layer. So you'd find that you put some drops in, it softens a layer of wax, you're able to remove that, and then the layer beyond it again, you just have to soften that again. You can see just how mushy that is. It's just like wet mud. It's a horrible consistency. I'm sure my colleague, my co-director of Clearwax, won't mind me saying, he's an ENT surgeon, Mr. Darius Rajali, and this is the same type of wax he has, and I'm quite often having to remove it for him. And his ears are much narrower, so it's a bit more of a complex procedure in his ears. So just at the roof of the ear canal, I've noticed this wax is a bit firmer, it's a bit harder, a bit drier compared to the rest of the plug of wax, and there's a few hairs matted there. So I'm just trying to go right to the roof of the ear canal, and we're quite deep in the ear, so we're probably about 2 centimeters in, so we are in the bony part of the ear canal. Just trying to bring this forwards, trying to create a little gap at the top so I can use another instrument to then get in behind the wax. So just tube got blocks, I'm just going back in with the Zollner suction probe, and again I'm just trying to get a suction grip and then just peel this forward, see if I can bring it down. You can see it's quite stubborn still. And here we are, I've just managed to rotate this plug, And that's because this part of the wax is a bit firmer and harder, so I was able to get a suction grip. And in the distance, you can now see the eardrum. However, this plug doesn't want to come out still, because beyond that, the wax is softer and it is stuck to the eardrum. So just thought I'll give it one more go, see if it comes out in one big mass. But again, it's quite mushy. I'm not able to get a suction grip, well, an adequate one enough to extract this. You can see there's a few hairs there as well that's also matted, which makes it a bit harder sometimes to get a suction grip. So I just thought, well, you know what, let's go in with the forceps. Let's see. And the idea behind this is I noticed those hairs and I thought, if I grip onto these hairs, maybe, I've been quite optimistic, that as I pull the hairs out, this wax, this matted wax that's attached to it would also come out with the hairs, but it didn't. The crocodiles just pluck the hairs out. So because I had got a gap now, I can now go in with the ear hook. So that ear hook I had to insert almost 3 centimeters. I was quite close to the eardrum, but there was an opening, so it was, as long as I was steady, I was able to get in behind it. But this remaining residual wax, it's plastered directly onto the eardrum, so there's no other instrument we can use. We can't use a Jobson horn, we can't use an ear hook, because we just can't get in behind this, because if we do, there's no option but to make contact with the ear canal wall. Patient will find it uncomfortable. Again, I could scrape and injure the eardrum as well. You can see that exposed bone there, so you can just see a thin layer of skin. Just on the right hand side now, you see the rim of the original canal wall, and just to the right, a layer of skin that's kind of healed over that exposed bone. So I've just put some drops in, I think, just to kind of loosen this last plug. Drops is so useful. I compare drops when removing wax, especially this consistency of wax, to an egg in a potato cake mixture or fish cake mixture. It binds all the ingredients together, and that's what drops does. It binds everything together. So the wax generally comes out in a plug. So this is this bony part, this is this dead keratin, and it's rock solid, it really is. So refer the patient to ENT, because we need to rule out both possible canal cholesteatoma, which is very, very rare, and as I said, more likely this is benign osteitis. However, prior to seeing it, you can probably just tell there when I was just hovering over the suction probe just how hard that was. It was just gliding over the top. So the patient's been advised to use sodium bicarbonate earwax drops. Sodium bicarbonate is really, really good with dead skin, better than olive oil. So you need to use it 3 times a day for 3 weeks, even before seeing an ENT doctor. And hopefully ENT, by that stage, that keratin will be really soft and they'll be able to remove it. If not, they'll have to get the patient to use drops for a bit longer. Patient will return, they will remove that keratin and then examine this crater, this expanded, corroded part of the ear canal, possibly undergo a CT scan just to make sure there's no underlying damage to any of the structures there. I hope you enjoyed that video, guys, and you're all having a good weekend, and I'll speak to you soon. Thank you. Bye.